It's one of the reasons I wanted to put this article out, because it, like you said, it isn't very practical to do pulse dye laser or other lasers or photodynamic therapy that we kind of touched on, because it's not covered by insurance. So I would hope that many of us in the military setting could take advantage of our ability to use this variety of lasers and treatment modalities so we could contribute to the literature and make them a little more mainstream. And then maybe in the future, some of them can be covered by insurance and can be used a little more frequently.
Military dermatologists play a unique role in managing acne because they need to consider the medical readiness of service members during treatment. In this episode of Dermatology Weekly, Dr. Justin Bandino welcomes two guests to talk about avoiding antibiotics or systemic drugs that can limit a service member's operational duty status, which can be applied to civilian health. This is episode 75 of Dermatology Weekly, where we bring you clinically relevant interviews with leaders in the field of dermatology. But first, the news in dermatology. I'm the host of the show, Nick Andrews. Coming up in the news, a medical student in Europe makes a clinically relevant handbook, and we have data on how treating psoriasis with biologics may impact the development of psoriatic arthritis. Remember, you can email the show at podcast@mdh.com. You can interact with us on Twitter at mdhderm. You can find any relevant links to the peer-to-peer portion of the show in the show notes. Nearly every edition of Peer-to-Peer in Dermatology Weekly is based on an article that MDH has written. You can find links to the original article or the downloadable PDF of that article in the show notes as well. Okay, it's time for This Week in Dermatology. We begin today with a deeper review of psoriasis guidelines. The most recent updated set of guidelines for the management and treatment of psoriasis include topical agents, alternative medicine, and disease severity assessment. These guidelines were issued in a joint statement by the American Academy of Dermatology and the National Psoriasis Foundation. They were published in the Journal of the AAD, which you can find a link to in the show notes. The guidelines follow the release of other recent guidelines from the AAD and the NPF back in 2019 on biologics for psoriasis, psoriasis-related comorbidities, pediatric psoriasis, and phototherapy. Earlier this year, there were guidelines on systemic non-biologic treatments. In the most recent edition of the guidelines, there is a section on topical treatment that outlines evidence for the efficacy, effectiveness, and the adverse events related to the following: topical steroids, topical tacrolimus and pimecrolimus, vitamin D analogs, tazarotene, moisturizers, salicylic acid, anthralin, coal tar, combinations with biologic agents, and combinations with non-biologic treatments, mainly methotrexate, cyclosporin, acitretin, and apremilast. The guidelines noted the key role of topical corticosteroids in treating psoriasis, especially for localized disease, and they include a review of the data on low, moderate, high, and ultra-high potency topical steroids for psoriasis. In general, the guidelines state that all topical steroids can be used in combination with biologics, but the strongest recommendations based on the latest evidence include the addition of an ultra-high potency topical corticosteroid to standard use etanercept for 12 weeks. Currently, 11 biologics are approved by the FDA for the treatment of psoriasis. The guidelines also address the evidence for effectiveness and adverse events in the use of several alternative medicines for psoriasis, including traditional Chinese medicine and the herbal therapies aloe vera and St. John's wort, as well as the potential role of dietary supplements, including fish oil, vitamin D, turmeric, and zinc in managing psoriasis, and the potential role of a gluten-free diet. In general, research on the efficacy, effectiveness, and potential adverse effects of these strategies is limited, according to the guidelines that were published, although many patients express interest in supplements and herbal products. For example, authors of the statement wrote that many patients ask about the overall role of vitamin D in skin health. Rather than adding oral vitamin D supplementation, topical therapy with vitamin D agents is effective for the treatment of psoriasis. In addition, the authors noted that the mind-body strategies, namely hypnosis and stress reduction or meditation techniques, have been shown to improve symptoms that can be helpful for some patients, but clinical evidence on that is limited. And the guidelines also addressed methods for assessing disease severity in psoriasis. The authors recommended using body surface area to assess psoriasis severity and patient response to treatment in the clinical setting. However, body surface area is a clinical assessment tool that does not take into account where on the body psoriasis is seen, the clinical characteristics of the plaques, symptoms, or the quality of life issues. The Psoriasis Area and Severity Index measures erythema in duration and scaling, and is more suited to assessing psoriasis severity and response to treatment in clinical trials rather than in practice. Dr. Alan Mentor is chairman of the Division of Dermatology at Baylor University Medical Center, which is in Dallas. He said that the key game changer from these previous guidelines were the full section that was published on comorbidities plus the development of two new important cytokine classes. Those two classes are 3 IL-17 drugs and 3 new IL-23 drugs that are now available for moderate to severe psoriasis. Dr. Mentor noted that barriers to implementing the guidelines in practice could happen when third-party payers make the decisions on which of the 11 biologic drugs that are now approved should be used in treatment. And a medical student has made a handbook for signs on darker skin. A black medical student in the United Kingdom has created a handbook to help trainee doctors recognize conditions on darker skin. His name is Malone Mukwendi, and he is a second-year student at St. George's University of London. He had the idea after only being taught about clinical signs and symptoms on white skin. The handbook he is creating is called Mind the Gap, and it contains side-by-side images demonstrating how illnesses and diseases can present in light skin and how they can present in dark skin. Mr. Mukwendi said that he hopes the book will help future doctors spot and diagnose potentially life-threatening diseases on Black, Asian, and minority ethnic patients. The handbook points to Kawasaki disease as an example. On white skin, it appears as a red rash, but on darker skin, it shows up a bit differently. It's much harder to spot. Mr. Mukwendi told Medscape that he and his collaborators are currently working on the best way to get the book out into the public. He's hoping for some time in the second half of summer in 2020. And finally today, some data on how treating psoriasis with biologics may delay the development of psoriatic arthritis. This is according to research presented at the 2020 virtual meeting of the Group for Research and Assessment of Psoriasis and Psoriatic Arthritis. In the study, researchers examined medical records of more than 1,600 patients with psoriasis who were treated at University Hospital Schleswig-Holstein in Germany between 2000 and 2019. There was a total of more than 15,000 years of follow-up. Of these patients, the researchers reported that nearly 1,300 were treated with topical medication, 229 patients were treated with conventional DMARDs, and 104 patients were treated with biologics. The researchers reported that overall, just over 9% of patients developed psoriatic arthritis. By group, the researchers found that 11% of patients in the topical treatment group developed psoriatic arthritis, 3.5% of patients in the DMARDs group developed psoriatic arthritis, and just 1.9% of patients in the biologics group developed PSA. Treatment with biologics was associated with significantly lower odds of developing psoriatic arthritis compared with DMARDs at 3 versus 17 per 1,000 patient years and a p-value equal to 0.0117. There was also a trend towards reduced odds of psoriatic arthritis when comparing biologics with topical therapy. However, those data did not achieve statistical significance with a p-value equal to 0.0588. And that concludes the news edition of This Week in Dermatology. Dermatology Weekly will be right back with Peer-to-Peer after this. Welcome back to Dermatology Weekly. I am Nick Andrews. It's time now for Peer-to-Peer. Please welcome our guest host, Dr. Justin Bandino.
All right, well, I'm Dr. Bandino, and today I'm talking with Dr. Catherine Brahe and Dr. Kristopher Peters about acne in military service members. Dr. Brahe is from the Naval Medical Center in Portsmouth, Virginia, and is currently serving with the 3rd Battalion, 6th Marines in Camp Lejeune, North Carolina. And Dr. Kristopher Peters is a staff dermatologist at the Madigan Army Medical Center in Tacoma, Washington. Thank you both for joining me.
Thank you for having
Thank
us.
you.
So just some questions to kind of chat through this article. What inspired you to write this article?
Of course. Well, as a military physician, I find that we operate in a very unique space in which we balance a number of varying priorities. This includes diagnosing, treating, caring for patients, serving as patient advocates, providing guidance in more of a medical advising type role to our command, and then working ultimately to preserve the force. And when I say preserve the force, I mean caring for the active duty members and working to keep them in the fight so that they can continue to train and perform their actual operational duties. A service member's duty status makes a huge difference in this operational environment, and I feel that military physicians play a really key role in affecting and determining that status. So I was initially inspired to write this review article, which discusses numerous treatment approaches to acne as a means to really highlight the unique challenges that military providers face in the treatment of common, otherwise simple diagnoses, and also just to stimulate conversation regarding the treatment of acne itself. In the military, we often speak about adapting and overcoming. And so the question is, why not extend that concept to medical treatment? This paper touches really briefly on the issue of antibiotic resistance, which is an issue that we all know is not going away anytime soon. And while we know that these antibiotics are a really efficacious treatment for acne, there may be other treatment options out there as well. Military physicians are often incentivized to try these other modalities as a means to avoid limiting operational duty status with the use of either certain antibiotics or certain systemic drugs like isotretinoin. But perhaps civilian providers may also consider them as well, and as a result end up playing a part in slowing the spread of antibiotic resistance.
Yeah, I agree with all that. I mean, that's kind of the basis of why we wanted to write this article. And I mean, there certainly is a significant need for something like this in our practice setting in the military, particularly with those who can't tolerate Accutane or can't take it because of operational requirements. And yeah, I also see a lot of patients who have been on oral antibiotics for well beyond 3 months. So I wanted to put something out there for us to explore some of these other options.
Yeah, and I really think you guys are aptly highlighting the operational status that makes things a little bit more unique. And, I was reading the article, as you mentioned, Dr. Brahe, you're talking about the medications, the potential limitations, that type of stuff. Something that just kind of struck me is even just the access to dermatologists. If someone gets deployed for 6+ months, unlike in the civilian world, where they can call up their regular doctor, they've got an acne flare, they can then eventually, it might take a few months, but they eventually see a dermatologist. It can be a lot harder for that to happen in the military world, especially if you're in a deployed setting or in the Navy, if you're out at sea. And so, everyone has to kind of play their part to include the PCMs that might be taking care of them and trying to get this information out there and broadcasting a lot of these additional treatment options are very useful for not just the dermatologists, but also non-dermatologists to try to account for some of that operational uniqueness that we have in the military. So do either of you have any memorable cases in which treating or maybe curing something that oftentimes people think is simple, as acne, any in particular cases that made a huge personal or maybe even an operational difference for you guys?
Definitely. So right now I serve with an infantry battalion of Marines in North Carolina. And doing so, my patient population spends a large amount of time doing really intensive training in the field setting. So this involves hiking long distances. They carry super heavy packs. They spend a long time outside in the actual field, like sleeping in the tree line, moving throughout vegetation, going through swamps. And so with that training, it wears a lot on their body. And I find that really common, simple things such as acne or even a horrible case of tinea pedis or some trench foot, poison ivy is very common, or perhaps even just a perfectly located pilar cyst, if left on its own, can really affect their operational performance. Just a few weeks ago, actually, I excised 2 pilar cysts from the anterior scalp of this young Marine. And during the procedure, he just kept commenting on how great this was going to be and how much more comfortable his Kevlar was going to be to wear moving forward. So you definitely see that little things make a huge difference. In terms of this article, which focuses on acne, I've had many patients who have really bad acne involving the face and back, and they dread shaving, they dread getting cuts and sometimes getting empatigenized later. And similarly, the hiking is really hard on their backs, especially with just rubbing and irritation, just from the main pack, rubbing as they hike. And so a lot of times treating that root problem, yes, gives them confidence, increases their comfort, but it just gives them one less thing to worry about when they train. And then you see them that they're better to focus, they better stay in the fight, and you really see that difference. So it's very rewarding for us to see that.
Yeah, I mean, this is such an important question because, I mean, when acne is so severe that they're referred to dermatology, our treatments can be so life-changing. For me, I remember in residency having a female teenager who came in, she was like wearing a surgical mask, which, before COVID wasn't normal for someone to come in wearing a mask. And and it's not just her, so many that come in, they're withdrawn, they're just really sad. And, after a few months of treatment, they start taking off the mask or, just getting happy. It's good for us to remember that kind of thing, that whenever we forget the importance of what it is that we do, we can remember patients like that. And as far as, making a difference operationally, just like Ali was saying, that when we can help them conform better to grooming standards and that kind of thing, because then a lot of them aren't able to shave when they have that cystic facial acne. It can really help them out in their careers, and not only just make them more comfortable, but make them presentable for promotional boards and that kind of thing too.
Yeah, those are all great points. And I think, sometimes as a dermatologist, and myself included, I sometimes forget how painful acne can be, particularly severe acne on the back. And particularly if you have to wear a rucksack or you're wearing Kevlar or other gear. I think it's just in your common day-to-day practice, we think about the cosmetics, which is important. And we think about the scarring, which is important. I mean, all the other factors. But I don't even feel like patients often bring it up very frequently, but it can be pretty significantly painful. And obviously the nodular cystic lesions, but even just back acne in general. And so I think that can make, pretty important difference in those that are deploying and operationally.
Yeah, definitely.
And when we think about military healthcare, sometimes there's pros and cons. I think there are a lot of pros, but certainly there's sometimes we look at civilian healthcare and there's some benefits there, obviously, that we maybe don't have in the military. But do you feel that military healthcare sometimes actually provides the opportunity for additional procedural or even treatment options that would otherwise not be covered by insurance in the civilian sector, and maybe actually kind of open up different opportunities that would be a lot more challenging to do in the civilian world?
Yeah, I agree 100% with that. I mean, it's one of the reasons I wanted to put this article out, because it, like you said, it isn't very practical to do pulse dye laser or other lasers or photodynamic therapy that we kind of touched on, because it's not covered by insurance. So I would hope that many of us in the military setting could take advantage of our ability to use this variety of lasers and treatment modalities, so we could contribute to the literature and make them a little more mainstream. And then maybe in the future, some of them can be covered by insurance and can be used a little more frequently.
Yeah, I think that would be great, because we sometimes have the advantage of having these tools and we use them for their medical indications. But, since we have the benefit of not necessarily worrying about revenue and those sorts of things, we have them sitting around, and I think it's good to use them for these other indications and make good use of them and take care of the fighting force that we're kind of responsible for. So getting more into the paper specifics, just something that I was thinking about as I was reading it. Obviously you talked a lot about PDL and even some of the studies where they compared PDL to other treatments. But have you guys tried anything, or do you have any thoughts on maybe some combination treatments? So, combining PDL with something else and maybe it's kind of augments it, or adjuvant therapy? Or do you think PDL is really best as a monotherapy?
Well, I wouldn't think of PDL as a monotherapy because it just treats active lesions. So what I really like this for, not only just to treat any kind of inflammatory acne that they have, but in particular, if they have a very inflammatory, like a nodular or a cystic lesion, if you double tap one of these, from my experience from this patient and from other patients that I've treated, there's a pretty good success rate. So that's what I would view as the major benefit with this. I still like to have all of my patients on a topical retinoid. And then if it's also on their trunk, benzoyl peroxide as well. So I try to have them all on all of those, except for our patient here so we could properly evaluate the use of the pulse dye laser. But in reality, I'll try to use the retinoid and benzoyl peroxide still, for sure.
Gotcha. Yeah, that makes sense. Almost more using it as like a rescue treatment,
Mm-hmm.
but it wouldn't necessarily be the mainstay. And I guess you certainly could. One patient category that I thought it might be additionally useful in is those overlap patients that have, they've got some true comedones and acne, but they've also got some papulopustular rosacea and then maybe some ETT rosacea. And so, maybe in those patients, you use it on more than just the kind of the more active lesions, and then you can kind of use it more full face and get that additional benefit. That might be another way to use it.
Yeah, that's a fantastic thought. That would be great to try this for rosacea lesions. And then you could also, like you said, treat both the papulopustular lesions and the telangiectasias. So I think that would be a great use for this as well.
Yeah. Do you plan, as a result of kind of diving into this information and writing the article, do you plan to increase the use of PDL as an acne therapy, particularly to maybe reduce antibiotic exposure and maybe have the additional operational benefits of limiting, individuals being grounded from flying duties or other operational limitations?
Yeah, I think so. And it's not just those people. I mean, obviously we can do it for them, and we can also do it for females that want to get pregnant. If they can't go on spironolactone, they can't go on Accutane. I have somebody that I'm treating there for some of the transitioning patients, female to male in particular, that are on testosterone, because iPledge still considers them females of childbearing potential. So they're not very happy about that. It's not pleasant to have that conversation. They don't like having it. So a lot of them are very open to PDL treatments as well. So yeah, I think I'll use it. I mean, like you were mentioning earlier, it's so awesome that we have this at our disposal that we can just use for patients who need it. They don't have to worry about the charge. We really just have to worry about if we have the time to do it, which is so different from the civilian community. So I'll certainly be using it more.
Yeah, and I think, you highlighted on the advantage, again, of having this in the clinic. And the PDL is just such a versatile laser, can do so many different things, but it's also just so quick, as long as you get it warmed up. Quick, it's efficient. There's essentially no downtime. And with these kind of indications, you're not even really worried about lots of purpura bruising or anything. So, it really kind of fits perfectly into this niche. Well, anything else that you guys would like to share regarding the article, or just your thoughts on kind of this patient population and the pulse dye laser?
I just want to thank you for having us on to discuss this topic. It's so important. I hope that we can come together as a specialty to limit the amount of antibiotic use, and also that we can also come together as military dermatologists to lead the way on this and continue to explore these procedural options that we have. Because like you said, it's so important that we prevent as much scarring as possible. And hopefully for those that have these inflammatory lesions that could potentially scar, we can use something like the pulse dye laser if we can't use one of the more traditional options.
Awesome. Well, thanks so much for writing the article and for joining us today and for your answers and discussion. And I just really appreciate it and agree with you and kind of that mindset going forward for our population. Thanks so much.
Thank you so much.
Thank you.
And that concludes this edition of Peer-to-Peer. Remember, there is a related article published with each Peer-to-Peer. You can find a link to the original article or a link to the downloadable PDF in the show notes. Episode 75 of Dermatology Weekly was produced by MD Edge editors Melissa Sears and Elizabeth Meshkati. All MD Edge podcasts are produced by MD Edge executive editor Kathy Skarbeck, as well as Medscape Vice President of Editorial, Dr. Ivan Aransky. I'm your host, and I also write and produce the show. I'm Nick Andrews, and this is MD Edge.